My work was on the effect of methotrexate in patients with erosive hand osteoarthritis refractory to NSAIDs and analgesics. It was a randomized, double-blind versus placebo-controlled trial. It was the first study on the effect of methotrexate in this disease. We conduct this study because several data previously published showed that the inflammation play an important part in this specific disease. Osteoarthritis is classically considered as a mechanical disease, but we know that 30% of patients with nodal or classic hand osteoarthritis move to erosive form. So, some authors try to use in this specific disease some therapeutics classically used in rheumatoid arthritis, such as anti-TNF alpha. These studies showed no effect on pain in erosive hand osteoarthritis, but it seems to have an effect on the structural evolution. It was why we try to use methotrexate in erosive hand osteoarthritis. The dose of methotrexate used in our study was 10 milligrams. Possibly it was too low, but when we were questioning of the design of the disease, we were asking about what dose to use in our patients. And we found that osteoarthritis patients were older and have numerous comorbidities. So we were questioning of the safety of methotrexate, and it was why we used only 10 milligrams. Our results showed that we don't have any efficiency on the evolution of pain at 3 months, and the same applies at 12 months. But if we look in intra-group, methotrexate group only showed a significant improvement at 3 months, about 17 points. And in the placebo, the improvement was only of 8 points, but it was not significant. So, our study failed to show a decrease in pain. It was our main outcome. And this signal of improvement in intra-group may conduct us to discuss why our study was negative. Firstly, maybe because the dose of methotrexate was too low. 15 methotrexate maybe was better. And secondly, because the placebo effect, which is known to be very important in osteoarthritis patients. An interesting result of our study is the safety. We showed no differences in safety between the two groups. So the questioning is 15 milligrams. Secondly, our results on structural evolution are interesting. Firstly, we showed that the predictors of erosive evolution was two inflammatory parameters, the synovitis at baseline and the rate of IL-6. It is a very interesting point, and this point underlines the importance of inflammation in erosive process. And our results, MRI results and X-rays results, showed that patients with methotrexate seems to have less erosions at 12 months, and patients with methotrexate showed significantly more remodeling phase. In erosive and osteoarthritis, the natural evolution of the disease is characterized by the succession of erosion and remodeling phases. Probably erosion is linked to inflammation, and remodeling phase is linked to healing process. When the inflammation stops, the healing process begins. And so it's an argument to question the use of methotrexate in early disease step of the disease. So the next step of our study is to perform an international study with a new design, with a new dose of methotrexate, and probably with a follow-up more important to more accurately precise the structural evolution.